Buenas noches, gracias a todos quienes se han unido hasta el momento al webinar de este mes. Hoy tenemos el honor de tener al doctor Oscar Coetzee. El doctor Oscar Coetzee es no solo nutricionista, médico y es parte de la sección educativa de Designs for Health. Entonces, detrás de todos nuestros suplementos está el doctor Coetzee presente, tanto en desarrollo como en esta educación que nos da no solo a nosotros, sino en diferentes países del mundo. El doctor Coetzee es surafricano y vive en los Estados Unidos hace bastantes años. Él tiene maestrías en psicología y en nutrición clínica. Y también él está en la práctica médica privada y él se enfoca en trastornos metabólicos como el trastorno del síndrome metabólico. Se especializa también en permeabilidad intestinal y todo lo relacionado con disbiosis intestinal, diabetes tipo 2, todo lo que tenga que ver con nutrición y rendimiento deportivo y el tratamiento de enfermedades crónicas. Entonces, él ha aceptado muy gentilmente acompañarnos esta noche y vamos a discutir sobre suplementación y abordaje del paciente adulto con déficit atencional, que es algo de lo que vemos en la práctica pues todos los días. Entonces, los dejo acá con el doctor Coetzee y entonces vamos a hacer la presentación de principio a fin y las preguntas que ustedes tengan las podemos escribir en el chat, por favor, para la sección de preguntas y respuestas que vamos a hacer al final de la presentación. So, Dr. Coetzee, welcome. Thank you very much for joining us tonight. We're all eager to hear you about this important topic, and I've told everybody that we will have questions and answers at the end of your presentation.
Great. Well, thank you, Jasmine. Thank you, everybody, for joining us tonight. Look forward to presenting this information to you. I kind of want to give you a little bit of maybe additional background in how I got into this area of mental health when it comes to, a different area of specialization. I have background in psychology. I worked as a drug and alcohol counselor, suicide intervention counselor at Psychiatric Institutes of America in New Jersey, and wanted to pursue my PhD in psychology. And at that point, there was a doctor there that said, there's very specific nutrients involved with mental health, that there's a new area of development like psychonutrigenomics that you might want to investigate. And that kind of put me on a pathway to where we are tonight. So I want to make it clear to you that I don't specifically specialize in ADHD. I think my area with the mental health is more in the anxiety and depression. But the idea that I want to bring home to most of you is that I think that there is a three-pronged stool effect when it comes to mental health, whether you incorporate ADHD, autism, anxiety, depression into that equation. It really doesn't matter. And the three legs of that chair is psychiatry, right? There's definitely a place for psychiatry. We have psychology, so there's psychotherapy and, psychological assessment. But the missing component of that three-legged stool is what I'm talking about tonight, right? So I feel that there's a big nutritional and genomic component that's overlooked in mental health. Now, why I'm mentioning all that is because I feel that when we're investigating ADHD in children and in adults, or anxiety and depression, people have some genetic predisposition to be more in the ADHD diagnostic criteria versus somebody that might be anxiety and depression. But we are, at the end of the day, working with very specific neurotransmitters, right? We are looking at dopamine, serotonin, and those kinds of neurotransmitters, where we will discuss those tonight as well. And I want you to understand, and I will maybe go a little bit deeper into that, into the discussion and Q&A tonight, that I've moved away from the isolation of ADHD and anxiety and depression and looked more at the microbes in the gut, the genes, the nutritional status of the individual, and then I tie it to what they are more predisposed for. So our attention tonight is going to be on ADHD. I don't want to lead you the wrong way. I just want to give you my vision and my understanding of working with mental health. And it's been a very successful approach to me to do it that way. So when I needed to come up with the discussion, I've done this presentation in Canada and Australia and, now Costa Rica, and I wanted to kind of dig a little bit into the literature that is available on ADHD in Costa Rica, and I didn't find a lot. Maybe some of you can guide me to more literature, and we'll look at the next slide. I did a little PubMed search and found like 15 articles that was published on this topic. But what we do know about ADHD when it comes to gender is there is this perception that men and boys are at higher risk for ADHD than women and girls. And if you look at the statistical data here, it's 12.9% compared to 5.6%. And one study that looked at the prevalence and screening for ADHD in Costa Rica found that there was a 5% overall prevalence, and 7% was in girls and 4% was among boys, which is interesting because that's kind of the opposite of what you're seeing, in the other studies. Now, in my opinion, I feel that there's a little bit of a misconception there because the maturity of girls versus boys are at different ages. I think you need to take that into consideration when you're trying to determine, some of these criteria. So I don't think the assessment criteria should be done at the same age if you really want to do an equal comparison on the boys and the girls. So just a slide that I put together, and I just put ADHD in Costa Rica and Costa Rica. And, this is kind of what I came up with. I scanned through a couple of these articles, and there wasn't really anything in these articles that we didn't know of before. So hopefully in this presentation tonight, there will be some information. So what I did was I specifically went into the literature and looked at ADHD. I didn't want to look at studies that had anxiety, depression, and ADHD and overlap. I wanted to look at what the literature currently is providing to us as far as ADHD is concerned, from an inflammation standpoint, from a gastrointestinal standpoint, from a nutritional standpoint. And what I'm going to be presenting to you tonight will have that. And by the way, I will be providing you with this presentation if you haven't already received a copy of it. So let's just look at the attention deficit hyperactive disorder market as far as pharmaceuticals are concerned. And clearly you folks are down here. So we can see that there's a 7.5% revenue share since 2022 when it comes to attention deficit and hyperactive disorder in this particular area. In 2022, there was $13.27 billion invested in ADHD and medication research. By 2032, they're looking at $20 billion. That's almost $7 billion increase in this area of distribution, right? Looking at increasing diagnosis. Some countries have government funding for ADHD medications. I'm not sure if that's the case in Costa Rica. I did see that there are certain restrictions on some of these medications, but these are clearly things like Ritalin and Concerta and Adderall, which you might want to consider. Is there really enough research to validate putting younger people on this? Now, I know tonight's topic is more about the adult ADHD, but it's not like you grow into ADHD, right? I mean, you have these particular indicators from a very young age, and as an adult, you either deal with it or you don't deal with it. So it's not something that I feel you get diagnosed with 35 because it started developing at 20, right? It's something that you clearly have had issues with. Now, the deeper dive that we're going to look at is what could be the underlying causes, or what could be the platform of the third leg of that bar stool that you could investigate to improve the outcomes of the patients, not taking away all the other ones. So let's look at the standard treatments for ADHD currently. So we have social skills training, we have prescription medication that we just mentioned, and there's a big drive for that, right? We have diet and nutrition that we don't have a tremendous amount of literature and research on. We have nutritional supplementation, which these two are clearly the discussion for tonight. Parenting skills training, physical therapy, physical activity, biofeedback, psychological therapy, educational therapy, sleep therapy, light therapy, and cognitive behavioral therapy. How I came up with these, I looked at the research studies, and I looked at specifically for ADHD, what were the clinical studies done on humans, mostly as it relates to ADHD. So this is what we are looking at. Now, the diagnosis of ADHD, which most of you might be familiar with, but let's just look at that again. So according to the DSM criteria, hyperactivity or impulsivity must include 6 or more of the following and be present for 6 or more months to be disruptive and inappropriate for a person's developmental level. So fidgeting, squirming, not being able to sit still, tapping drums, fingers, not staying seated, running or climbing when it's not appropriate, not staying quiet, talking excessively, often answering questions before the full question is posed, often has trouble to wait their turn, and they often butt in. Now, I'm going to tell you that there are several other reasons that people could potentially have these portrayal of symptomology, right? I mean, sometimes it could be they bored in a subject matter, or you know, they might just feel that the person that's talking doesn't know enough about the topic, and they get irritated with the information. So even though psychology is one of my graduate degrees, I feel that the diagnosis on some of these psychological assessments are too baseline and too subjective, right? We need to be able to find other things that we can look at as underlining adjacent assessments for ADHD. So look at tonight's lecture more about where we should be going as a profession rather than what we've created, because there isn't that much out there at the moment for that third leg of the bar stool. Here's something very interesting. If you look at the comorbidities for ADHD, so approximately 2/3 of people with ADHD have comorbidities. Now let's look at those comorbidities. So according to the CDC, 1 in 4 people with ADHD also have autism. 1 in 10 also have depression. 1 in 5 also have bipolar disorder. 1 in 5 also have anxiety. 1 in 2, and this is why I highlighted them in red, have oppositional defiance disorder. So they're quick-tempered, angered, they're argumentative, vindictive, annoying, and blame others, right? 1 in 4 people with ADHD have conduct disorders. So they have issues with lying and truancy and stealing and fighting and hitting. 1 in 10 have speech problems. 1 in 2 have sleep disorders. So maybe we need to start looking at these 1 and 2s, right? 1 out of 2s, to really start looking at some of the underlying things that could be exaggerating or exacerbating ADHD. Learning difficulties, dyslexia, dysgraphia, and dyscalculia here is a problem. So they have problems with math, writing, and just overall, processing of information. That's 1 out of 2. 1 out of 10 have substance abuse issues. Then other common comorbidities include oral health. This is an interesting one for me. Tics, thyroid disorders, and epileptic seizures. And then 1 in 10 with Tourette's syndrome. So when we're looking with this population, I think it's really important to take this into consideration and maybe deal with other associations in these comorbidities to help alleviate ADHD symptomology. Now, I'm going to go through these deficiencies in zinc, omega-3s, and magnesium, and this will make more sense to you at the end of the presentation, right? So if we're looking at human zinc deficiency, and we're looking at, your part of the world right here, you can see that there's a high prevalence or a moderate prevalence of zinc deficiency, right? So our soil is depleted in zinc supply and other minerals, and we can blame agricultural pesticides and herbicides. But this is a very important one because there's several studies that indicate the correlation between ADHD and zinc issues, okay? If we then further go over to the right side and we go look at the omega-3 status, you can see that there's moderate associations here and the levels of omega-3. Maybe you don't have as much because you have such an ocean exposure, but omega-3 we need to talk about because of the association to brain-derived neurotropic factor, right, which is a big, big component of ADHD. And then magnesium deficiency. You all know as physicians and functional practitioners the amount of magnesium deficiency and insufficiency that we see in patients. Now, in America, only 25% people are above the RDA, which is the recommended daily allowance. Now, we know that that's created by the American Dietetic Association, which is shameful in its own way. Below RDA, 55%, and well below 20%. So you can really effectively say that 90% people have a deficiency in magnesium. Maybe that sleep issue that you see in the ADHD patient that's in 1 in 2 people might just be a magnesium issue. It might be a melatonin conversion issue because those people might not have enough vitamin B6. And all these things would make a little bit more sense to you when you go back to those comorbidities and start to look at the nutrient deficiencies that are in the literature. So keep in mind zinc deficiency, omega-3, and magnesium, right? And as we all know, magnesium has 300 functions in the body that we know of. Vitamin D deficiency. Let's just go to bottom part of the United States and the upper part of South America. Again, in this area, we're looking at between 36 to 59% of people that are vitamin D deficient. Now, you tell me how that is possible. Now, I grew up in South Africa, and I don't know how many of you have been in North Africa, but I have. 60% of people in North Africa have vitamin D deficiency. So please don't tell me it's the sun or the lack of sun, right? Many of you have been in North Africa. There's a lot of sun there, right? So there's something else going on. Our bodies are using up the vitamin D potentially because of immunological suppression, because it's highly involved with T regulatory cell development. And you can see the association to neuropsychiatric disorders when it comes to vitamin D, right? So keep the vitamin D involved in the memory banks as well. Now, let's go talk about fiber. Now, I don't have Costa Rica in here, but we have Mexico, Chile, and some other Southern American countries involved. And let's just look at the overall lack of fiber in people's diets, right? America is woeful here, and Brazil, look at Brazil at 15%, USA at 16%. Now, if you look at anecdotal data, right, from primal ancestral history, people speculate that people used to eat between 50 to 150 grams of fiber a day. Now, why is that relevant? Well, it's severely relevant when we bring the microbiome into the equation to the discussion, right? Because the short-chain fatty acids, they feed off the bacteria in the gut, feed off the fibers that make the short-chain fatty acids that help us with so many things in our life from a neurological standpoint, right? So fiber intake is another key component that I would like to look at. Then B vitamin status. Not many people are focusing on B vitamins. When you take B9 or folate, you take vitamin B12, and specifically vitamin B6, when it comes to mental health, ADHD, anxiety, depression, you need to understand the level of B6 in people's body because of the importance of that vitamin and conversion of neurotransmitters. And I also put prediabetes, blood sugar dysregulation, hypoglycemia, and dysglycemia in here because a lot of people with attention deficit disorders are also more prone to have blood sugar dysregulation, or they might be more hypoglycemic. So we have to start focusing on all those components when we're working with these people, rather than just saying one supplement or one intervention is highly recommended. Now, the things that I'm mentioning to you are very strongly supported in the literature, and it's definitely a great baseline to work from. Now, let's quickly go through some of the information here. Let's look at the neuroinflammation as a risk factor for ADHD. So we spoke about the comorbidities for ADHD, but inflammatory and autoimmune disorders seem to be also associated here. So some studies initially indicated increased serum cytokine levels, and maybe I'll explain that a little bit better when we talk about stool testing at the end of this presentation. There's also several studies that look at genetic associations, right, and polymorphisms, and then environmental risks. These are the three major areas that seem to be indicated in the literature. Now, if we look at the inflammation hypothesis, if we look at the gene for interleukin-1RA, this is involved with the gene expression and cell adhesion and inflammation. There seems to be some issues indicated with SNPs with people with ADHD in that category. This was in the studies back in 2015 by Zayetz. Some meta-analysis found that there are a very strong association between atopic immune disorders were significantly associated in ADHD than controls. There's also been an association found between excessive pro-inflammatory serocytokines that we just mentioned a little bit earlier. And this was interesting to me when I looked at this research here. There's higher levels of anti-basal ganglia antibodies and antibodies against dopamine transporters. And we know that if you look at the initial research on ADHD, that it is seen as a dopaminergic and a serotonergic problem, right? So if we further go into the inflammation hypothesis, we can see that elevated cerebrospinal fluid levels with pro-inflammatory cytokines, especially tumor necrosis factor beta. And then there's very low levels of interleukin-4. And this information has been available since 1997. So what exactly is going on with the inflammation? Maybe the inflammation with these people are driven in the gut, right? And we need to kind of focus more on that as the origin of the problem. Then microglia is heavily discussed as well. Now, microglia, as you know, are the immune cells in the brain that help us, fight off various things. But they can also go into overdrive where that neuroinflammation becomes so aggressive because of permeability that it might cause scarring and can have other central nervous system effects. So we need to have a deeper dive in the overall blood-brain barrier permeability, gut barrier permeability, when we're trying to really understand the inflammation hypothesis. Now, if we further dig into this, so studies have indicated that the microglia exhibit a sex-dependent phenotype, especially in the male microglia, because apparently they exhibit more pro-inflammatory phenotype and develop at delayed rates. So this is where the male and the female discussion comes in. Furthermore, ADHD have on average approximately 4% reduction in overall gray matter in volume in both the cerebrum, cerebellum, and the prefrontal cortex. So there's clearly physiological attributes here, right? It's not just some theoretical psychological theory of ADHD. There are abnormalities in the brain and the microglia when it comes to the ADHD patient. So what do we do about that, right? We need to lower the allostatic load of the inflammation to drive less of these microglia to be in that hypervigilant state in order to, improve the outcomes of that. So let's look at the history a little bit of catecholamines and its association to ADHD. So if we look at ADHD, it was often considered to be a hypodopaminergic disorder. And you can look at that way back in the studies as early as 1991. So it's basically a deficiency in synaptic dopamine is what they found. So as we know, dopamine's role in ADHD has been supported by certain medications, right? Like amphetamines that increase the levels of dopamine, and they seem to temporarily ameliorate the symptoms of ADHD. Now, sure, if we work with dopamine, and dopamine is the problem, and you might see that dopamine is not the only problem, and some people don't respond to dopamine therapy, then we might need to look at, okay, well, why are they low in dopamine, right? Are there other issues that make them not convert the dopamine properly from tyrosine, or what else is going on? And then furthermore, dopamine converts to epinephrine and norepinephrine, and there are also studies that investigate that and implicate that in ADHD. So if we look a little bit deeper into some of the genes, especially when it comes to dopamine encoding, the dopamine transporter genes like the DAT1, DAT4, and DAT5, they seem to play a role. So if you're doing any kind of genetic testing, you might find that there might be information in that patient's genome that you might want to address. The gene SLC6A3 has also been associated with ADHD in children and in adults. And then the FOXP2 gene has been significantly associated with ADHD when it's involved with the dopamine and the neurodevelopment, which we spoke about earlier, which is the speech and the linguistic association with dyslexia, dysgraphia, and dyscalculia. So the first line of treatment for dopamine generally in the traditional sense is going to be dopamine upregulators, right? Now, only 30% of ADHD patients or 70% of ADHD patients have success with that. 30% of them do not respond to that. So we need to dig deeper, right? Then we'd go into serotonin, all right? So we know that serotonin is a monoamine, and it is very much involved with behavioral inhibition. And that is clearly the problem with ADHD. The main site of serotonin is in the dorsal raphe, and there are certain enzymes involved with that, like tryptophan hydroxylase 2, TPH1 and TPH2. These are also genes that we can look at, that we are starting to investigate when it comes to ADHD. So the treatments for these are SSRIs and SNRIs, as you know, with some positive outcomes. But again, are we just not recycling low serotonin? Are we not supposed to maybe investigate why that person is low in serotonin in the first place, right? So we do know that a reduction in serotonin via tryptophan depletion leads to inattention, reduced behavioral inhibition, and increased impulsivity. So what we know so far is that there's certain nutrients that we're all deficient in. We know that dopamine and serotonin are major players in this condition. We know that some medications work for people, but that is not really necessarily addressing the underlying cause. Now let's dig a little bit into the microbiome, right? And talk a little bit about the microbiome, and then we'll bring all of this stuff to a conclusion and a summation. So when we're looking at the microbiome in animal studies, certain infections and pathogens like Campylobacter jejuni and Citrobacter induced ADHD behavior, whereas supplementation with probiotics that include Lactobacillus rhamnosus and Bifidobacterium longum alleviated these ADHD symptoms. Now, when we have time, maybe tonight, I can go a little bit deeper into Bifidobacterium longum strains, and there are very specific strains of that is very unique in its peptidoglycan and exopolysaccharide design that has the ability to really get brain inflammation down. And there's been several studies on that, and I think we really need to move in that direction. But you can see the Bifidobacterium and the Lactobacillus species improve ADHD symptoms. Now, just think about that logically, right? Lactobacillus, Bifidobacteria are involved in aromatic amino acid production. Aromatic amino acids are tyrosine, tryptophan, and phenylalanine. Tyrosine converts to dopamine. Tryptophan converts to serotonin. Serotonin converts to melatonin. So maybe that's why this is working, and we know that this is a serotonergic and a dopaminergic associated issues. So here's another interesting one. Lactobacillus and Bifidobacterium species convert aromatic amino acids, as I just mentioned. And we can pick this up, by the way, folks, in looking at organic acid testing, right? We can look at this respective aromatic lactic acids like indolacetic acid, phenylacetic acid, and 4-hydroxyphenylacetic acid in organic acid testing to see if that conversion is happening properly. Further investigation, bacterial species of Clostridium perfringens modulates the synthesis of serotonin and the expression of tryptophan hydrolase, the TPH1 and TPH2 genes. So it's interesting to me that when you look at autism, the research on autism, there's been a very strong correlation between Clostridium. So there's also something that plays a role here in the ADHD category. Glutamate converting to GABA, which is part of, the overall feel-good neurotransmitter and chemical, that is also something that requires very specific nutrients for conversion that I'll show you in a couple of seconds. Now, remember earlier, I showed you that Campylobacter jejuni had a negative effect on the outcome for ADHD in animal studies, but it seems to have a positive effect in the studies in humans, which is unique, right? So you always have to wonder, is it really that bacteria that's causing the problem? Or is that bacteria in an overgrowth state because the other ones are maybe lower in their status? So I'm not always going to jump and say that this bacteria is the cause of the problem. Let's eradicate this bacteria. Why is that bacteria elevated? What else is low that is potentially naturally competing against that bacteria? So it's not always going to eradicate the bacterial strain, right? So what we also know is that the gut microbiome regulates the expression of brain-derived neurotropic factor, and the administration of Lactobacillus plantarum increases brain-derived neurotropic factor levels. The gut microbiome also directly influences the glucocorticoids and immune mediators such as tumor necrosis factor alpha, interleukin-1 beta, and interleukin-6, and the HPA axis. Now, I really want you to remember these, okay? The tumor necrosis factor alpha, the interleukin-1 beta, and the interleukin-6. And I'm going to show you something very interesting about tryptophan when it comes to those inflammatory cytokines. And here it is. If we look at tryptophan's normal conversion, right? Tryptophan's normal conversion is going to go to serotonin, then to melatonin, and this has a neuroprotective effect, right? So basically, you're going to have better sleep. And remember, what do you have in 1 and 2 ADHD patients? You have sleep issues, right? They can't sleep. So when this pathway is working well, your gut bacteria is producing enough aromatic amino acids, you can have a nice pathway to circadian rhythm improvement, positive outlook, resiliency to stress, good memory, and possibly less issues with ADHD. However, if you have microbial dysbiotic state and you have your cytokines that convert tryptophan to kynurenine by virtue of this enzyme called indolamine 2,3 deoxygenase, you can go down the wrong pathway. And when you go down the wrong pathway, you end up with elevated cholinergic acid. This is neurotoxic. This induces depressed mood, irritability, resistance to stress, poor sleep, and concentration. Those are very ADHD-like symptomology. So what might be worth your while is when you do organic acid testing and you look at the tryptophan conversion pathway, see if you have elevated cholinergic acid. If you have elevated cholinergic acid, it means that interferon gamma, interferon alpha, tumor necrosis factor alpha, interleukin-1 beta, and interleukin-6 that we spoke about earlier are in high overdrive. So the microbial imbalance is driving the inflammatory cytokines, which is clearly going to drive the HPA axis and create fight-or-flight responses, stressed and wired, which are great obvious symptoms of ADHD. So really important to kind of follow the pathway of tryptophan when you're looking at organic acid testing dealing in the population of ADHD. We talked earlier about GABA. I just want to quickly take you through a little biochemistry. So alpha-ketoglutarate in the Krebs cycle uses an enzyme to make glutamate. Glutamate converts to GABA. What vitamin do you need? Vitamin B6. If you don't have enough vitamin B6, the absorption of vitamin B6, you cannot do that conversion, and that is going to be an issue in neurotransmitter development. If we look at tryptophan, what do you need? For tryptophan to get into the blood-brain barrier, this is the blood-brain barrier, you need insulin-dependent active transport. So what does that mean? A person should not have blood sugar issues. If they have natural insulin response, they're insulin sensitive, then that conversion happens properly. Tryptophan, in order to convert to the 5-HT, you need iron. For that step to go to serotonin, you need vitamin B6, B12, folate, and magnesium. For serotonin to convert to melatonin, you need zinc and magnesium. Remember earlier I showed you the deficiency of zinc and magnesium? Serotonin cannot convert to melatonin. 1 and 2 ADHD adults cannot sleep properly. Maybe this is the underlying problem. Maybe blood sugar is the underlying problem. Maybe iron deficiency anemia vitamin B6 is the underlying problem. So we need to fix blood sugar. We need to fix absorption. We need to get the allostatic load of the bacteria in the gut to be lowered so that the LPS that is produced by gram-negative bacteria don't drive those cytokines in our bodies. We go from phenylalanine to tyrosine, tyrosine to dopa, iron, B6, dopamine to norepinephrine, vitamin C and copper. You know that in America, 25% of the patients are borderline scurvy, right? So vitamin C deficiency is a commonality where we are, and that conversion cannot happen properly. And if you go from norepinephrine to epinephrine, obviously SAMe plays a role as well. So you can see the importance of proper blood sugar, proper mineral and vitamin status when it comes to the conversion of it. I spoke to you a little bit earlier about the fibers, right? And the importance of fibers. We all know that the intestinal microbiome produces short-chain fatty acids, butyrate, propionate, and acetate when it has the proper degradation of the fibers and the undigested saccharides. If you're not eating enough of those things, you cannot produce them. So what we also find is that the short-chain fatty acid may actually combat oxidative stress. And it upregulates some of these antioxidant enzymes like glutathione. So the fiber is a lot more than just feeding the microbiome. It's really the short-chain fatty acids that are helping the oxidative stress. And if you don't believe that ADHD is a state of oxidative stress, you probably need to rethink that. So if we look at, additionally, butyrate also has anti-inflammatory properties that induces the release of the anti-inflammatory cytokines of interleukin-10, which inhibits the pro-inflammatory cytokines of interleukin-6 and interleukin-12, which has come up consistently, right? All these pro-inflammatory cytokines. So really dealing with the GI tract with ADHD, I think, is a very, very important area to look at. And I do believe that a lot of you do a lot of GI map testing. It is really important to look at these gram negatives and see where they play a role from the inflammatory driving standpoint. So if we look at this study from ARTS, they found differences in adult patients with ADHD with the phylum Actinobacteria, and the genus of Bifidobacterium was significantly increased in the adult ADHD cohort. That's really interesting, right? Because you would think that Bifidobacterium would be low, because that is the one that is involved with the aromatic acid production. But look at what it does. This genus of Bifidobacterium increases an enzyme called cyclohexadinyl dehydratase, or CDT, which is involved with the synthesis of dopaminergic precursors of phenylalanine. So maybe this is a compensation mechanism. Maybe the body is really driving higher levels of Bifidobacterium because it's trying to convert dopamine to deal with the problem, right? I always look at medicine as what is the body trying to fix rather than what's wrong with the body, right? The body is a very self-intuitive mediation mechanism, right? It's always looking at ways to steal from Peter to pay Paul to be able to have successful remediation. Let's look at Faecalibacterium prausnitzii. So they looked at treatment-naive ADHD children and compared that with a cohort of healthy adults. What they found was no significant differences in alpha or beta diversity between the groups, but a significantly lower concentration of Faecalibacterium was reported in the ADHD group. Faecalibacterium may exert anti-inflammatory effects, and their abnormal levels may lead to a higher expression. Now, if you're looking at a lot of stool testing clinically, I'm sure that you're seeing a lot of tests with low Faecalibacterium prausnitzii, low Akkermansia, and low Roseberia, right? All of those kind of do a similar anti-inflammatory job. We look at the Enterococcus species. Now, the Enterococcus can be seen as an opportunist, right? So we do know that Enterococcus is associated with neurotransmitter release. But if there is too much of it, it could lead to excessive conversion of intestinal dopamine, And because this dopamine or peripheral dopamine is not able to cross the blood-brain barrier, it is not really that effective. And significantly higher level of the Enterococcus species also lead to decreased serotonin concentrations. So both these things are obviously a problem, as we know, in ADHD. Let's just look at a really simple little study. There was a double-blind, placebo-controlled study that looked at ADHD and participants that took a blend of vitamins and minerals and antioxidants. And they had significant improvement in the indicators of ADHD. Now, why would that make sense? I mean, we just learned all the vitamins and minerals that are deficient in those steps to produce dopamine and serotonin. We learned how deficient our world is in these minerals. And we learned about all the antioxidants that play a role with those inflammatory cytokines and the oxidative stress in the body with ADHD. So this would make sense, right? They didn't change anything else. They just put them on a blend of a multivitamin and some antioxidants, and there was pretty good improvement. So the micronutrient supplementation caused a significant decrease in the phylum of Actinobacterium, and several studies reported a protective effect of the Bifidobacterium longum strain that I mentioned earlier that has real positive effect on neuropsychiatric disorders. Let's just look at something as simple as omega-3. Remember earlier in the presentation, I showed you the omega-3 association. So omega-3, especially DHA and EPA, as we know, is important for membrane fluidity and neurotransmission. It affects brain-derived neurotropic factor and glial cell-derived neurotropic factor. Low brain DHA content is associated with frontal cortical dopaminergic hypofunction. So maybe those early signs of brain issues that we pick up in that younger group of children with the cerebellum and the prefrontal cortex is because there's lower levels of DHEA. What does DHEA also do? It reduces interleukin-1 beta. And that is the thing that showed us again on that tryptophan conversion pathway, neurotoxic versus optimal, right? So total omega-3 polyunsaturated fats are significantly decreased in the patients with ADHD who showed a significant higher ratio of omega-6 to omega-3. Now, I don't know what it looks like in Costa Rica, but in the United States of America, it's looking at 10 to 1, maybe as much as 15 to 1 omega-6 to omega-3s. So a lot more pro-inflammatory issues going on. On a microbial level, there's also a significant increase in Firmicutes and Bacteroides ratios. And that was observed in diets deficient in omega-3 fatty acids, whereas diets abundant in omega-3 showed significant increase in lactobacillus and bifidobacterium. So what can we learn from that? Our microbiome can really do well with the omega-3 ratio going well. This is just an example of a 8-week randomized control trial that looked at the omega-3s and how it affected ADHD. And this is just a kind of a cool graph to show you how effective it was at modulating the microglia, the inflammation, and it's a pretty interesting study to look at. I put a lot of studies here. I'm not going to go through every one of these. Just wanted to show you some of the studies that we looked at specifically on ADHD. You can see that we looked ADHD only, and you can look at all the findings on these, like we mentioned some of these earlier tonight, where there was no difference in alpha and beta diversity, but there was a significant difference in Faecalibacterium prausnitzii in these populations. So spend maybe a little time and go through these, and you'll find some consistencies of inflammation, microbial overdrive, or maybe some of these species that are seen as culprits, but I think that they are just kind of doing more of a balancing act. Okay, so let's just quickly get into a conclusion phase here. Sleep disorders, as you know, came up initially in 1 out of 2 patients. So 70% of patients affected in their neurocognitive, behavioral, and physical state because of sleep deprivation. People suffering from ADHD have variable sleep disruptions, delayed circadian rhythms, disturbances in daytime functioning. And there's something going on with melatonin secretion with these people. Might be worth to look at the clock in the ARNTL genes to look at the susceptibility when it comes to this. This is why you will find some studies indicating pretty significant improvement in ADHD with the use of melatonin. Now, I don't personally, I'm not the biggest fan of using melatonin permanently with people. I feel that you need to get that tryptophan with proper blood sugar regulation, with vitamin B6, with proper iron status, with all the other nutrients involved, magnesium and zinc, to get a person to sleep properly. So if you can get a person to fall asleep on tryptophan, you clearly have that whole pathway fixed up, right? And that might be a good thing to look at when you're working with this population. So also we found that there was diverse abundance of certain species, again, Bacteroides and Clostridia, swayed during the light-dark period. So the microbiome actually shifted when this was going on as well. And then melatonin by itself as a supplement seems to have an impact on the richness and the diversity of the intestinal microbiota, especially the Firmicutes and Bacteroides ratio. So decreases in Akkermansia, Bacteroides, Caelibacterium prausnitzii, together with increase in Aromonas, was found in sleep deprivation. This same study looked at goblet cells and tight junction proteins and found that permeability was more driven when there was a decrease in these species. And we all know that, right? The lower the commensal status, the higher the susceptibility of permeability. However, after treatment with melatonin, there was a significant decrease of the Aromonas and a rise in the Akkermansia, Bacteroides, and Faecalibacterium prausnitzii. That's without supplementing these people in precursors or polyphenols of these anaerobic bacteria. That's just giving them melatonin, right? And furthermore, melatonin significantly increased the number of goblet cells and proper expression of the tight junction proteins. Lactobacillus rhamnosus, there was a study that looked at this, and it reduced the pro-inflammatory interleukin-12 and tumor necrosis factor alpha significantly, and significantly lowered the concentrations of the pro-inflammatory interleukin-6. And then breastfeeding, it was shown in this study that breastfeeding for a minimum of 3 months was associated with lower scores of inattention and hyperactivity. Now, the breastfeeding thing and vaginal birth thing might play a massive role with a microbiome, right? And maybe that is why the inattention and hyperactivity is so much less abundant in children that were breastfed. And in another study, a probiotic formulation that consisted of a standardized combination of Bifidobacterium infatis and Lactobacillus acidophilus, administered once daily from days 1 to 3 of life until days 14 to 35, also showed positive outcomes in the categories of inattention. So in conclusion, we know that serotonin, glutamate, GABA modulate dopamine transmission. We know that there are certain perinatal insults that could drive inflammatory pathway upregulation. We also know that environmental factors like maternal smoking, pollutant exposure, maybe even herbicides and pesticides could be an influence and a risk factor for ADHD. So we need to take these things way back. But I just wanted to show you a couple of studies in conclusion here. Magnesium, iron, zinc, copper, selenium status in attention deficit hyperactive disorder. So in summation, they found that low thalamic iron levels may play a role in the pathophysiology of ADHD. Case-controlled trials in several geographical areas demonstrated lower zinc levels in children diagnosed with ADHD. Higher copper concentrations led to lower dopamine levels. Low intake of selenium was observed in ADHD groups compared to controls. Lower magnesium levels are reported for patients with ADHD. Now let's take it a step back. Remember the steps and the nutrients needed to convert tryptophan and tyrosine to dopamine and serotonin. Iron, zinc, Copper plays a role with the conversion of dopamine to epinephrine, norepinephrine, and magnesium, right? And this is probably also why that multivitamin study with that one population indicated improvement in ADHD. Vitamin D status. In conclusion of this study, systematic review and meta-analysis, we found modest but significant lower serum vitamin D concentration in children and adolescents with ADHD compared to healthy controls. Lower perinatal and childhood vitamin D status were both associated with high likelihood of developing ADHD. So maybe we need to pay attention to that a lot earlier. This study, again, looking at omega-3s, but look at this one. It's interesting because it also included omega-6 GLA, right, in the study at a ratio of 9, 3, and 1. Now, why that's interesting is because GLA is omega-6, but it's also the only anti-inflammatory omega-6, right? So you have a really good compound here of anti-inflammatory omegas, and we know that this is a real issue in ADHD, is the neuroinflammation. So what is the intervention at baseline? Generally speaking, an anti-inflammatory diet would be very helpful. Look at your omega-3 to omega-6 ratio and include GLA. Look at the circadian rhythms, sleep hygiene. Consider a multivitamin. Look at short-chain fatty acid butyrate-producing anaerobes and feeding them and fiber. Really dig into the dopamine and serotonin conversions. Look at permeability, reduce dysbiosis, and in some cases, if you want to really work with the melatonin, right? This is kind of what the literature is supporting if we are focusing exclusively on ADHD indicators. So I added this slide in for you, and I know that you might not have this exact test, but I just wanted to show you, like if you're looking at neurotransmitters, right, or an organic acid test, you do have the tryptophan to quinolinic acid, right? So we can look at that pathway. We can look at tyrosine. We can look at GABA. We can look at stress hormones and cortisol versus the HVA-VMA ratio. So there is your HPA axis, stressed and wired, stressed and tired. It's also very interesting when you're looking at the autistic and the ADHD population. They have an issue with fatty acid oxidation. I found that in several anecdotal studies. That's why I just didn't add it as a major component. But carnitine deficiency could be a problem as well. Really important to look at this. These are your gram-negative bacteria. And if you look at a GI map test and these gram-negative bacteria tend to be high, they are driving LPS. If you also have elevated zonulin and that LPS is getting into the bloodstream, you have permeability and an inflammatory upregulation. Now, remember that whole tryptophan kynurenine pathway that we spoke about? The driver of the conversion of that enzyme down the kynurenine pathway is the inflammatory issue in the gut, which is what you can pick up here. We looked at Faecalibacterium akkermansia, some of these anaerobes. We looked at the Enterococcus species in our discussion tonight, so it might be worthwhile to do some of these functional tests to get a little bit more information about how they can assist you in assessing these patients. I'm not going to stay on this because I'm not sure that you have all these, but these are some of the supplements that are associated with what we spoke about tonight. And let me open it up for Q&A at this time. So do we have any questions?
Yes, thank you very much. We have a few questions and all regarding doses in the pediatric population.
Doses as far as the supplementation.
Omega-3, yeah, supplementation. So there's a specific question about omega-3s, and for how long do you recommend that patients are taking omega-3s and omega-6s if necessary? And should there be a ratio, an adequate ratio of EPA to DHA when it comes to supplementation?
Yeah, I mean, if you're looking at that study, you looked at that ratio from 9:3 to 1, right? And I mean, I would base kind of my theory on that implementation. As far as the dosing is concerned, I think that's going to depend on the level of deficiency. So generally the theory would be a quarter dose of an adult, right? Give or take.
Mm.
But sometimes I go higher with that dose if I'm suspecting, severe deficiency in children, because I mean, the worst thing I've ever seen with advanced or upper level dosing in omega-3 is gastrointestinal bloating and maybe a little bit of diarrhea, but I would probably go progressive with that. So in a younger population, quarter to a half a dose, I think, in omega-3s of what the adult recommendation would be fine. Now, that is a very debatable question. What is adult recommendation, right? Some people recommend 1,000 milligrams. Some people recommend up to 6,000 milligrams. I think that's where the individual practitioner needs to, make that determination on their own purely by the symptomology and the indicators maybe of what the the omega-3 deficiency symptomology looks like.
So you're recommending long-term supplementation with omega-3s?
100%. I mean, if you're looking at the deficiency, especially if you're dealing with an ADHD patient, I think it's very important because of the brain-derived neurotropic factor association, right? So all the microbiome and the bacterial species involved with the BDNF drive, as well as the omega-3s. Yeah. Look, personally, I don't use supplements on any patient permanently, right? I mean, I'll go out and in dosing with patients, and then if the symptomology is improving, I will reduce the dosing. But unless that person can indicate to me that they have substantial intake of omega-3 in their diet by virtue of, fish intake or, algae, intake, I would tell you that you're pretty safe going to the route of consistent exposure.
Supplementation. Yeah, that's a very important point for all of us here, especially, for example, dietitians in our country.
Yeah.
They believe that they don't believe as much in supplementation because they think, you can acquire all of your nutrients from your diet alone. So, here it's very important for us to learn how our nutrients need to be in higher doses, in therapeutic doses that will not show enough in our diet.
Yeah, and look, if we go by, and I'm not knocking the dietetic world at all, I think they do phenomenal work. But if we go by the recommendations that are set forth by the generalized governmental recommendations, remember those recommendations are based on prevention of scurvy or rickets or something to that effect, right? I mean, when we want to move the needle on a functional level, we need to go to therapeutic doses. Now, what that is with a child versus an adult, that has to be a little bit of the decision of the individual practitioner. But at the end of the day, I have had children that I've worked with in this area where I've given them adult dosing, because their intake of omega-3 is null and void. They also might have fat assimilation problems, right? They might have a gallbladder issue. They might not be assimilating fats very well. Or they might not be digesting and absorbing particularly well. So you also have to take that into consideration, when you're working with this.
Okay. So we have another question, and this one is regarding probiotics.
Yeah.
And probiotics, especially for children, right? So are probiotics a kind of supplement that you can also give permanently to our children? Is that safe to do?
It's definitely safe to do. I don't have a concern with people taking probiotics, but you also have to remember that, if you're looking at, let's say you're looking at a person with maybe a small intestinal bacterial overgrowth, right? And a person has a high level of, let's say, opportunistic bacteria, but they also have a high level of probiotics or commensal species. I don't necessarily think that you need to overdrive that system.
Exactly. Yeah.
I am more a believer in the probiotic intervention is done when you know that the commensals are low and you want to stimulate kind of, that communication and reinvigoration of the microbiome. What I'm a bigger believer in is feeding the microbiome the right things.
Yes,
Like
absolutely.
your Akkermansia, Faecalibacterium, Prausnitzia, those anaerobes rely on polyphenols. They rely on fiber. This is why I bring up that I think a big part of our mental health issue in the world systemically is our lack of fiber intake. We're
Yes.
not feeding the microbiome. We're not diverse enough in the microbiome. And this is why I make such a big push and such a big emphasis on fiber intake.
And still in our country, what we see, on a daily basis is probiotics are given, in a very allopathic way of thinking,
Yes.
single strains. And that's all you do, and maybe if you're lucky, maybe for a month or less than that. So how do we change this, this way of thinking in what you're doing of thinking about diet and thinking about diversity and thinking of how are we going to feed our microbiome? Maybe some of our attendees tonight are not doing GI maps, right? Because that is kind of new for us here, and that's what we're working on. So most of what Dr. Coetzee has explained tonight, referring to the microbiome, is based on test results, right? We do the GI map testing, like I do it on a daily basis in my own practice, and this is how we can direct our patients, to understand why we do what we need to do, what are the right supplements, what are the right doses, so that we can see, significant clinical outcomes.
I totally agree with you there. And in answer to the question, the single strain probiotic theory, it's not the way the microbiome works, right? Again, I feel that the microbiome, if it is high in a specific species, it might be just because it's low in another species, and I think I want to really bring that home to the practitioners. And you have it completely right, Jasmine. If you're not doing this, you need to start implementing functional stool testing. That is the basis of being able to determine, are there LPS driving gram-negative bacteria involved in this process? Is there permeability that leads to blood-brain permeability? This is what we know is really, so if nothing else tonight, if there's a lot of complicated information in this presentation, take home just this message. The microbiome somehow drives neuroinflammation. And the answer to ADHD systemically, if you look at the breastfeeding of the moms, the natural birthing of the moms, and the lower rates of ADHD, is a microbiome issue. What we do with the microbiome now, how does that tie into the nutrients, the vitamins, and the minerals? Well, the bacteria in your gut is part of the extraction methodology of the nutrients, right? So our lower commensal status and our lower microbiome health might lead to less absorption, that leads to less magnesium, that leads to less iron, that leads to less copper, and that leads to more ADHD. So you systemically, and I know it's easy to say all diseases start in the gut. We're far beyond that statement now. We can physically quantify by looking at GI map testing as, do you have LPS overgrowth? Do you have high Enterococcus species? The Enterococcus species, tonight we learn, drives serotonergic suppression. So a person with elevated Enterococcus species, maybe you need to use a short-term antimicrobial to bring down that load, while you then alternatively at the same time are feeding them with probiotics. But sometimes you don't want to give a person a probiotic. Sometimes you don't want to give them fiber initially. You might need to first bring down the overgrowth of whatever is bad, and then, kind of the remove re-inoculate 5R approach to gut health. And the only way that you can really do that is through stool testing. So when I'm working with any kind of neurological anxiety, depression, I do metabolomics testing or organic acids, and I do stool testing. And then clearly, all these genes that we mentioned tonight, they're great to know about, but I first want to fix all those other things.
Yeah. And I think it's important to take into consideration the adrenal stress index as well, right?
Exactly.
It should
Major
be
player.
like,
Yeah.
All right. We have a question here that says, as far as the diagnosis of ADHD in adults, should the right approach be according with the literature that has been stated in this presentation, that once made the differential diagnosis, could be indicated that adults get pre-medicated with SSRIs, melatonin, GABA, and recompensation of the microbiota with probiotics. So saying, is this a good way to get started? That's why I understand from
No, I don't think it's necessarily a good way to get started on an SSRI temporarily, because you don't know if the tryptophan, serotonin, or the dopamine is the problem, right? We know that both dopamine and serotonin play a role with ADHD. There are more natural ways to investigate that. Now, again, I'm not anti the use of the medication if somebody is really in a state where they need to kind of regulate their mental status or their ability to focus and concentrate. But your answer is always going to lie in natural upregulation and conversion of serotonin, natural control of dopamine by virtue of proper pre and pro status of the microbiome, and then inflammation reduction, right? So the other side of the question is the diagnostic criteria. I'm not trying to change the diagnostic criteria of ADHD. I think the questionnaires and the measurement from a psychological perspective is helpful. But I think what we need to do as a community is start saying, hey, if we have elevated Enterococcus species, that might be an indication if a person has ADHD as a driver of that. If they have elevated a gram-negative LPS producing excess, that could be a driver of neuroinflammation. So you attribute those areas also to the diagnostic criteria. You understand? So that the 3 legs of the bar stool that I spoke about, the third leg of the bar stool has no diagnostic criteria right now. So we need to implement these basics. And this presentation tonight was more, here's what I would do as an assessment of true ADHD, right? So I can determine if that person is converting tryptophan properly. I can determine if they are converting to melatonin. I can determine if they have enough bifidobacterium and lactobacillus. I can determine if they have neuroinflammation. So I can go look at those individual components. Now, you don't need all of them to be present to have ADHD. You might just need 2 of them to be present. But you as a practitioner, you need to address all of those areas that you see out of range that we spoke about tonight if you want to have an impression on that condition.
Yeah. So I would say in a nutshell, because these tests are available in our country, but they are more expensive than regular tests. If we are sitting in front of a patient with ADHD, in our consultation, what is in your experience, the most basic supplements that we could recommend our patients with the dietary changes that we're talking about, fiber and all of this?
Very simple. Omega-3s,
Omega-3s,
a multivitamin. I think you're covering your bases there. If you want to go real baseline, you're not going to be negative.
Can you repeat
there.
for me, please?
Fiber, a proper multivitamin, right? It contains the iron, the magnesium, and all those, right? And then omega-3s. Those would be my baseline to start with. Then I would do the investigation of the gut and see what I can do with some of the other species.
Okay, and in order, when it comes to iron supplementation, is that something that you would do or recommend in the absence of any proof of iron deficiency?
No, not at all. I'm just saying that iron deficiency could play a role with it. So make sure that if there is anemia, that you know that that is a systemic associative cause. But if there is no anemia, you completely scrap that, out of the equation.
Yeah.
No, absolutely not.
So choosing a good multivitamin without iron for these patients who do not need iron supplementation.
Yeah, and you can maybe just give them the multivitamin without iron, and then just enrich their iron sources of food.
Yes.
If there's a deficiency of iron, or make them eat more red meat or something to that effect, right? The human body is very good at absorbing iron. You have two pathways to bring in heme and non-heme iron. So, bring it in the natural sources, but it's probably not the best idea to do a standardized iron
Yes.
vitamin, right?
That's what I wanted to make it clear.
Yeah.
Perfect. Okay, excellent. So those would be, I think those should be our questions for tonight.
Okay, great.
But excellent. So, we have a great starting point as we, grow in our knowledge of functional testing, this gets more exciting, by the day. So, we have access through different laboratories in our country to the GI map through diagnostic solutions, and we have access to organic acid testing and metabolomics. And I think that should be an area of growing interest for all of us who do functional medicine and all these practitioners who are open, to, incorporating new therapies into, their allopathic practices, which
Yeah,
we see that a lot.
in the future, we could probably just take a GI map apart, and I can show you, here's the areas on a GI map that could be indicative of mental health, right? And here's the areas
Perfect. That
of
would
the
be
GI
great.
map that
Yeah.
could be indicative of small intestinal bowel overgrowth or whatever. And I'm sure that I'm not going to teach anybody anything that they don't know, but I've really dissected these tests into the mental health sphere, right? So these tests is me going down the mental health, anxiety, depression, ADHD categories, more so than just saying, hey, you have IBS. So, that's definitely something we can probably make.
Yeah, we definitely need to do that because, those are the conditions that we treat on a daily basis
Exactly. Yeah,
for most people.
anxiety, depression, blood sugar, weight loss, resistance, right? Those are kind of the commonalities that we all deal with in chronic disease.
Okay.
So cool.
Thank you.
You're
We're
welcome.
very thankful to have you and share your knowledge with us.
You're
So
welcome. I hope some of your audience learned something. And if there are any more questions, Jasmine, that we didn't answer, maybe wait a couple of days and put them all on one document to me and email them, and then I'll answer them for your.
Yeah. And we will have access to your presentation, right?
Yes, I'll email it to you first thing tomorrow morning. Is that okay?
Perfect.
Okay.
That'd be great.
Terrific.
All right. So thank you so much and have a wonderful night.
You too. Take care.
Okay. Bye-bye.